Welcome. Thank you for joining the immunization program here in Philadelphia this afternoon. We're going to be talking about the introduction of the newest immunization product, nirsevimab for RSV in outpatient settings. So as we get started, just wanted to make a note that this town hall will specifically talk about implementing the new RSV product nirsevimab in primary care and other outpatient settings. If you have questions about the implementation process for birthing hospitals or other inpatient settings, please reach out to our team following this call so that we can get you connected with the information. The product will be available in both settings, but the process, the administrative part of it looks a little bit different. So to keep the conversation clear, we set up 2 separate meetings. If you have any questions about that, please feel free to reach out to our team. So for those of you that I haven't had the pleasure of meeting yet, my name is Jillian Brown. I am the Deputy Immunization Program Manager. There are a number of immunization team members on the call this afternoon, but today you'll be specifically hearing from Hannah Lebo, who is our IAS Informatics Manager, and Victor Obeck, who is our VFC Coordinator. So just a quick overview of our agenda. I know it looks a little bit intense, but it's just because we're going to cover some of these topics really briefly. But we're going to just do a quick overview of the disease burden of RSV, a little bit about how we got here, preaching to the choir here, but did want to mention it. An overview of the new product by Fortis or nirsevimab, a little bit about administration and storage and handling. Hannah's going to take over and talk about reporting to Filovax with this newest product. Victor is going to talk to you all about how this is going to be rolled into VFC, and then just gonna have some time to talk about what does the implementation look like. We've had a lot of unprecedented opportunities over the last couple of years, and this is our latest one. So we just want to make sure that as we're all moving forward and thinking through the implementations of rolling out this product, that we're thinking along the same lines. And then finally, we'll hope to have a lot of time for just open discussion and to be able to hear about your questions and concerns and answer as many as we can. So we'll just start off with our disease burden for RSV. And so sorry about that. I disconnected myself for a second there. Could someone give me a thumbs up if you can hear me and see my slides?
We can hear you, Jillian, but I can't see slides. I'm not sure if anyone else.
Thank you, Hannah. All right, we should be back on track there. Sorry, thought I could get through this without any technical challenges, but not quite. Okay, so as those of you who work in clinical settings know, RSV is the most common cause of hospitalization in U.S. infants. It's the highest hospitalization rates in the first months of life, and risk declines by a month with increasing age in infancy and early childhood. Prematurity and other chronic diseases do increase the risk of RSV-associated hospitalization, but most hospitalizations occur in healthy term infants. And these statistics were a large part of the reason why the ACIP work group felt that RSV associated disease in infants born or entering their first RSV season is of public health importance, and what brought us to this discussion today. And so this is the potential impact of this new product, nirsevimab. If nirsevimab were to be administered to all infants, it could prevent 100,000 medical interventions due to RSV in the US every year. That's an increase in office visits by 300,000, a decrease of over 100,000 emergency room visits, and a decrease in hospitalizations for about 50,000 infants. So the impact could be really profound. So how did we get to this town hall today? So on July 17th of this year, the FDA licensed Beyfortus or nirsevimab as a long-acting monoclonal antibody for the prevention of RSV in infants and young children. And on August 3rd, the Advisory Committee on Immunization Practices, or ACIP, recommended this product and its inclusion in the Vaccines for Children program. We'll talk more about that as we go along. So a little bit on the technical side, nirsevimab is a passive immunization. That's why we're not calling it a vaccination. Its protective effects can last for 5 months. Active immunity results from infection or vaccination, which triggers an immune response. Passive immunity of this type is when a person receives antibodies from an external source, passed on from the birthing parent to the baby in utero, or through breast milk, or direct administration of antibodies such as an IVIG or monoclonal antibodies, which is this product. So that we're all talking with the same language, nirsevimab is thus an immunization, but it's not a vaccine or a vaccination because it doesn't impart long-term protection. Administration is very similar to other routine vaccines that are available for children. It's administered as an intramuscular injection using a single-dose pre-filled syringe, and it can be administered simultaneously with other childhood vaccines. Ideally, nirsevimab should be administered shortly before the start of RSV season, typically in October, and we'll talk more about what that will look like this season since it's new. However, nirsevimab may be administered to age-eligible infants and children who have not received a dose at any time during the season, and that ranges from October to March typically. So for the first season, infants can receive 1 dose of nirsevimab for healthy infants who are less than 8 months of age based on weight. So if they're under 5 kilograms or 11 pounds, they would get the 50 milligram dose. If they are 5 kilograms or more, or 11 pounds or more, they would receive 100 milligrams. And then for infants who are 18 months of age to 19 months of age in their second RSV season, who have been determined to be at increased risk of severe RSV disease, 1 dose of nirsevimab, 200 milligrams administered as 2 100 milligram injections given at the same time at different injection sites should be administered. And so this is just a way of thinking about the season. So infants that are born April through October would start to get nirsevimab October, November, hopefully earlier in the season, but can continue to receive it through throughout the season, November through March. And then I alluded to it earlier, we're working with the birthing hospitals so that infants that are born during RSV season have the opportunity to get a dose before being discharged from the hospital. packaging and pricing. So these are just some images of what the packaging looks like. The pre-filled syringes look very much like other routine vaccines that are available on the market. Sanofi has color-coded them so that the 50 milligram dose has a purple plunger, and the 100 milligram dose has a blue plunger. It is not an inexpensive immunization product. Beyfortus will be $495 a syringe for both dosages when purchased privately, and 395 doses a syringe for both dosages through VFC. Storage and handling, again, is very similar to other routine vaccines. It's stored between 2 and 8 degrees Celsius, or 36 and 46 degrees Fahrenheit, and may be kept at room temperature. So that's 20 to 25 degrees Celsius, or 68 to 77 degrees Fahrenheit for up to 8 hours. It should be noted that after removal from the refrigerator, it must be used within those 8 hours or discarded. And then it is a light sensitive product, so it should be stored in the original carton and should not be exposed to freezing temperatures, shaken, or exposed to heat. Because it is an immunization and falls under a drug or medication, reporting of suspected adverse events is a little bit more complicated for Imcivrimab than other immunizations. So if Imcivrimab is administered alone, suspected AEs are reported to MedWatch. If Imcivrimab is reported simultaneously with any vaccine, suspected AEs are reported to the Vaccine Adverse Event Reporting System, or VAERS, the way that other vaccines are. Additional reporting to MedWatch is not needed. So you would, whether it's administered alone or together, you would just be reporting to one agency. All right, I'm going to hand things over to Hannah to talk about reporting.
Great, thank you so much, Jillian. Like Jillian said earlier, my name is Hannah Lebo. I'm the IIS Informatics Manager, and I'm going to talk to you a little bit about reporting this new immunization to Filovax. So I'm sure many of you already know a lot about Filovax, but just as a little reminder, Filovax is an immunization registry. It's also a secure web-based application that offers healthcare providers like yourself consolidated records, immunization records for your patients, and also offers recommendations based on the most recent schedule, immunization schedule. And I believe all of you know this as well, but all healthcare providers in Philadelphia are required to report their administered doses to Filovax. And basically, we just want to make sure that everyone understands Beyfortus is viewed in the exact same way as other vaccines. So this immunization is also required to be reported to Filovax. And there's two different types and there's two different specifications of this vaccine. This immunization, like Jillian was saying. So there's the first dose is for the slightly smaller children under 5 kilograms in body weight. And it's the 0.5 milliliter dose. And then the second dose is 1 milliliter. And there's two different CVX codes for these different immunizations. And it'll be a little bit easier to get into your EHR system, but both versions need to be added to your EHR system so that you can, when you administer either dose, you can report them. And we just kind of laid out the differences here. So you'll see this is the first one. This is the CVX code 306, and this is the smaller dose. So this is 0.5 milliliters. And the yellow is showing what's going to be different between this dose and the next one. So you'll see a lot of the things are the same. The route's the same. You saw the packaging was different. Obviously, the name is the same, but the CVX code is different. The dose is different. And you see there are 4 different children. And you can go to the next slide. And then this is the second one. So don't worry about writing any of this down now. We're going to send out these slides after the meeting. And then additionally, our team is going to send an email out to the technical contacts at your site so that they can start working with your EHR vendor to get these added to your EHR system, and then it'll be easier to report them.
Thanks, Hannah. All right, I'm going to talk a little bit about VFC. Hello, everyone. Victor Obeck, the VFC coordinator here for the city. All right. So real quick, what is a immunization doing in the VFC program? Long story short, because the CDC's voted for it. There's no statutory definition of what a vaccine actually is in the VFC program. So basically, because the CDC has okayed this, it's all right to be in our VFC program, so we can offer it through there. Go on to the next slide here. Let's see. So we anticipate having nirsevimab available early October. So before the RSV season, right there as it starts. Sometimes it can take a while to get the actual product added into our inventories and put into the government stock, but we're hoping to roll this out as quickly as possible. Let's see here. This is important though. The VFC providers, you're required to carry this as it's an ACIP recommended immunization. So you're going to need to carry this for whoever your patient population that you serve is, whoever's VFC eligible. So you should start planning ahead to order the vaccine through the VFC program, but also purchasing this on the private market for your patient population. Providers who, let's see, I'm sorry, yeah. This last point here, providers enrolled in VFC cannot refer VFC patients. So yeah, just want to make sure that we're also clear about that yeah, this isn't something that we can turn away patients for because this is a required one. Okay, next slide. Okay, so basically what this is going to mean for you is that as providers, you should start looking at your EMR now to assess how many current patients would actually be eligible for this. Basically, you're going to be looking for your population that's 19 months or younger. Of those, yeah, between under 8 months by the age of October, would definitely want to get them in for RSV shot. But 8 to 19 months age is would be looking for children who are at risk for severe disease. Okay, sorry, that's all.
Thanks, Victor. Thanks, Hannah. I forgot to mention earlier, if you have any questions, please feel free to drop them in the chat or come off mute. We just have everybody muted to avoid background noise, but we do want to hear from you and start a discussion to help start planning for this immunization to be available. So our team has put together a planning checklist that we'll also be sending out in our follow-up email. Sorry, this should say this week. And the checklist has different things to keep in mind as you're planning for having nirsevimab at your site. So setting up reporting, as enrolled VFC providers, you already have storage and handling set up. Having staff education, this product is a little bit different. You have the added indication of weight that isn't a factor for other immunizations, patient education, and then timing of the product as well. And so this just walks you through it. Some of the points are more geared towards birthing hospitals than your setting, and so just keep that in mind as you're looking through the checklist. So I pulled some of those points from that checklist here to start our discussion. So you want to make sure that you're establishing a process to make clinic staff aware of nirsevimab availability and recommendations so that they're familiar with the dosage and how it differs from other products. Plan how to communicate nirsevimab availability, priority groups, and safety and efficacy to patients. And we're hoping to get more information from CDC and other agencies and we'll be sharing that throughout the season to help you with talking to parents. Ensure education on documentation needs, EHR, electronic birth, I think that's supposed to say electronic medical record, Filovax are provided to staff. Develop a process for outpatient clinic administration to infants born outside of RSV. So basically, you know, how are you going to be offering it at your practice? How are you going to be identifying those kiddos that are that were released from the hospital before the product was available or outside of RSV season, and co-administering it with other vaccines? So I'm gonna pause here and pull up some questions from the chat. For healthy infants, do they need to be under 8 months or 9 months at the time of injection? Sorry, I always get this wrong. So they can be it's up to 8, so through the 8th month of age. And Sharna Blake has a great question as well. Do you know if there's any issue in PA with medical assistants administering this immunization? We have not heard of any issues with that the same way with other vaccines, but I will double check with our clinical team. Unfortunately, they weren't able to join this call today because of a conflict, and so I will take that question to them and get a direct answer for you. And Jacqueline, another great question. If a child does not get nirsevimab in October, November, but is only 8 months at the December visit, can we still immunize? Absolutely. Is there going to be a VIS, a vaccine information statement? I believe so.
Actually, Jillian, I think I heard the answer to this one. Actually,
Oh,
there will not
perfect.
be one because
Yes.
it's not a vaccine. So yeah, there won't be a VIS.
Thank you, Victor.
Not a vaccine.
Right. Great questions. Please keep them coming. Again, along with the questions that you've had earlier, establish a mechanism to inform parents of infants born outside of the traditional RSV season of the need to return for nirsevimab. So calling those kids back in October, November, and throughout the season to get them protected. And then developing a process for administration of nirsevimab to infants at higher risk for RSV complications entering their second RSV season. And then before I go back to the chat, I want to make a pitch for our Philadelphia Immunization Coalition annual conference meeting. So on Wednesday, October 4th, we'll be meeting right here at the Muter Museum, and we'll have 2 presentations that focus on RSV. So Dr. Andrew Kroger will be talking about influenza, RSV, and COVID. And Dr. Paul Offit will be talking about the maternal RSV vaccination, which was not the topic today, but we should be hearing more about in September. All right, so I'm going to go to the chat. So if a healthy baby is born 10 pounds, no issues, do they need immunization? Yes. They are still, so most of the hospitalizations for RSV are in healthy full-term infants. And so it would be recommended during that first season for them to be immunized. And Deborah, you said that you saw the VIS on the CDC website.
Just looked up too. I think you're right. I do see a VIS listed here, so I guess there is a VIS. Maybe I was misinformed. Although funny, that was a CDC meeting. Yeah, it looks like that, but yeah, that might for the 16 older.
Right, yeah, right, it might be for that's likely for the another RSV product that is going to be available. Thanks, Sharna. Dr. Morale, that's a great question. We don't know yet if an infant born to a mother who has received her RSV vaccination would need to get Beyfortus. So ACIP is actually meeting in September to talk about the product that would be administered to the birthing parent, and how that would affect the administration of Beyfortus. Sorry, that word escaped me for a second there. And so we will get additional guidance right now because that product has only been approved by the FDA, but hasn't been reviewed by ACIP. Infants right now would be eligible for Beyfortus. And then we would update that based on the ACIP discussion next month. Great questions. Please feel free to continue to drop them in the chat or come off of mute and ask them directly. While we're waiting for the next question, just wanted to put a plug in for what Victor was talking about earlier for for VFC, and thinking about ways to take a look at what you would need to order. In the coming weeks, so that we can plan together. Leah, thanks for your question. To get this added to our EMR, we need the CPT and NDC numbers. Where would we get those? And so those are included in the slides here, and we'll be sending them out after the meetings. Vanetta, thanks for your question. So the immunization only affords protection for 5 months. So right now, the recommendation is that it's given during RSV season when infants are most at risk for being exposed to RSV. And that season is typically October through March. So it right now, it isn't advised to be given in July. For babies that are born preemie, the guidance is a little bit different. Because while they're in the hospital, they're considered cocooned, and so the hospitals would work to determine the best time for Beyfortus administration. And again, we don't have guidance as far as the RSV vaccine that was approved by FDA for administration to the birthing parent. So we won't have guidance on how the 2 products will be used going forward until ACIP meets in September. Dr. Morelli, yes, the ordering process is the same as for other vaccines through Filovax. So it will be added in as a product there. You'll be able to order it with the same cadence as other vaccines. So for this season, it would be ordered with the routine vaccines, excuse me, and you'll be able to order routinely every 25 days. But as it is a new product and it's going to be hard to gauge the amount that you need, you can reach out to our team if you need to order more in between your routine orders. Jacqueline, right now, the way that our system is set up in Filovax, nirsevimab will be available to order only during our monthly order. It's unfortunately not set up to order like flu as needed. So Lily, is it mandatory? Yes. So if you see patients that are eligible for RSV, so you see those kids 8 months of age and younger, then yes, you would need to have it available because as part of the VFC program, you're required to carry all the ACIP recommended products that are available through VFC. If you're not seeing children who are eligible for the product, we wouldn't want you to carry it. So it's really based on your patient population. Anthony, I'm gonna read your question so I can make sure I get all of it. I understand your obligation to provide this as a CDC ACIP recommendation and our obligation to provide protection for both VFC and privately insured patients. What will be the obligation of private insurance to cover this non-vaccine immunization? That's a great question. We are continuing to get information from the CDC. They have been working with private insurers to make sure that this is covered, and we'll continue to provide information as we get it. Laura Baker, any recommendations for co-administration of this plus COVID, flu, and routine vaccines? There doesn't seem to be enough muscle mass to administer all. Right now, the recommendation is to co-administer it at different anatomical sites. And I will bring this question back to our clinical team to provide guidance on the best way to give that number of immunizations and vaccines at the same visit. Dr. Morelli, is there a patient information brochure to give to parents? Right now, no. So because it's not a vaccine, our understanding right now is that there won't be a VIS. But what's not clear is if there will be like a CDC created information to give to parents. Sanofi will have literature that's available, but I don't know if there'll be any non-branded information available at this time. I see that the questions are slowing down a little bit. So I'm going to make another another one. So the Beyfortus or nirsevimab can be administered. There's no spacing considerations between this and other vaccines. So if someone came in, they got COVID, flu, and they returned for another visit 2 weeks later, they would be eligible to receive the nirsevimab or Beyfortus. It could also be administered at the same time. So I know that this was scheduled until 1, it's 12:36, so please keep the questions coming. But if there are more questions at this time, again, this is an emerging thing. As we get more information, we'll continue to share it out. But we wanted to have this opportunity to come together and share what we have at this time. And be able to share, to provide an update, get everybody thinking about the product becoming available in a couple of weeks, and then continue to send your questions to us in between. Laura Baker asked, can this be administered when a child is in like Synagis? I'm going to defer to our clinical staff, so I'll take that question back to them and reply back with our included a response in our follow-up. So Here is our contact information, myself, Hannah, and Victor. If you have any questions, you can email any of us and we will get you connected with the appropriate person in immunizations. Thank you for joining us this afternoon. Oh, another question was added. Does an infant that gets Synagis need Beyfortus? I'm gonna also take that question to our clinical team so that they can provide an answer. All right. So I won't keep everybody longer. Thank you all for joining us this afternoon. We'll be sending out an email with a copy of the slides, a copy of the recording, the checklist, and some answers to the questions that we weren't able to answer this afternoon. And again, if you think of anything else, we will continue to send that out. We're here to continue to answer questions and to walk with you through the implementation of this product. Natalie, I cannot say what the ECIP will say about the vaccine in pregnant women and its effect on Beyfortus. Anything would be just speculation. So more to come in a few weeks when the ECIP meets. Thanks, everybody. Take care.